All right, welcome, guys. This is Dr. Wong with Next Level PhysicalTherapy. We're starting a brand new series of the best healthcare providers of Kingwood, Texas. I'm super excited today. I got my colleague joining us, Dr. LeBrun. For those of you who don't know him, he is part of the Fondren Orthopedic Group. He is an orthopedic surgeon that specializes in hip and knee replacement surgeries. Welcome to the show, Dr. LeBrun.
Dr. Wong, thank you so much for having me. I'm super excited to be here, super excited to have this chat with you.
Yeah, for sure. Before we get into the meat and potatoes of all the questions that my patients ask me through years, about their knee and hip operations, I just kind of want to know what made you decide to want to become an orthopedic surgeon?
Yeah, so it's a good question. So I was an undergrad at Rice here in Houston, and at that time I thought that I wanted to do tumor surgery. Like my mom had cancer, she is a cancer survivor. I thought I was going to be taking tumors out of people. I wanted to be a surgeon from a very young age. I thought it'd be cool to help people and use my hands to be able to do that. So I thought I wanted to be a tumor surgeon. Then I had the opportunity after Rice to travel abroad for a year, actually, and through South America, Southeast Asia, Europe, Sub-Saharan Africa. And what I was focused on was understanding how surgery is delivered in low resource settings. And one of the first things I did during that year, I actually was a translator for a group of American surgeons who were coming down to Peru in the Amazon rainforest to provide orthopedic surgical care to this community in sort of an isolated region of Peru. So I was a medical translator, essentially. And that was the first time I ever saw an orthopedic surgery, and it was actually a hip replacement. I remember vividly this patient. It was like he was about 40, 45, a younger guy. He had been a barber and the sole breadwinner for his family. He got in a car accident, broke his hip. There was no care at the time to be able to address his hip. So he just went on to develop what we call non-union, where his hip never healed. So he couldn't walk. So this group of surgeons comes down to Peru, identifies him as a surgical candidate, gives him a hip replacement. I remember seeing the case, took an hour. I remember seeing the patient the next morning up, walking around. Whole life had changed, right? And from that point onward, I realized orthopedic surgery is a very powerful thing, right? Hip and knee replacement can change people's lives. It's a quality of life procedure, right? And it can make people's quality of life significantly better. So from that point onward, I was orthopedics all the way. I went to med school. I entertained everything, but it was orthopedics was sort of what drew me to really make a difference in people's lives. And so from that point onward, I wanted to be an orthopedic surgeon.
Yeah, that's amazing. That I met a lot of healthcare providers throughout my career, and a lot of times the ones I meet, they have such amazing stories of how they got started. And usually it's because they experienced something that, traumatized them and they decided to go in medicine, or they've seen something that changed someone's life and decided they want to be part of that. So that's a great story. I love it. So in the orthopedic surgery world, what makes you different from other orthopedic surgeons?
Yeah. So, I think a lot of it comes down to my training. And so, I mean, you're from New York, right? So you know this hospital well, but I trained at the Hospital for Special Surgery in New York City, and I know you know this, but Hospital for Special Surgery is sort of the mecca of orthopedics in the States. It's on the rankings, it's the number one orthopedic hospital in the States, number one orthopedic hospital in the world. I mean, they do a lot of hip and knee replacement there, and the people who taught me are the ones that really pushed the envelope in terms of advancing patient care for hip and knee. Many of them design the implants we put into patients. They design the robots. They're the ones teaching all over the world. So they're the ones that taught me how to operate. And so I come with that background. And then after my training in New York was done, I was actually given the opportunity to go abroad. And I received what's called the Mueller European Traveling Fellowship. So I actually went to Europe for a few months and got to learn from master surgeons in Europe. So I went to Germany, Italy, Switzerland, the UK, and I got to take, the best of New York, the best that the States had to offer, and then the best of what Europe had to offer, and sort of consolidate that into my own practice. So that's what I bring to Kingwood and to Houston, is sort of a mix of these different techniques, the best of New York, the best of Europe coming together here. So that's sort of what I bring to the table.
As a surgeon, do you find that the techniques that we use in the States versus internationally are different, or they're, very similar?
It's a really interesting question. I think in some ways they're very similar, right? So the implants, the robotic platforms, they're pretty much the same between the States and Europe. There are more like subtle things that people do in Europe that I had not seen in the States, like peri. So injecting anesthetic around the joint replacement, like in surgery, so that when the patient wakes up, they're not in a ton of pain, and seeing different techniques for how to do that wasn't necessarily done in the States. And then in terms of the more like complex surgeries, I've in Germany, I visited the primary joint infection center of Germany, where pretty much all the joint infections go to this one hospital, and that's like their specialty. That is what they do day in and day out. And so I got to sort of learn their techniques, which are a little bit different, very efficient techniques to deal with infection, a really tough problem in a hip replacement or a knee replacement. So that mostly similar, but there are some unique differences between the two.
In the healthcare world today, one of the common complaints we get from patients is that, sometimes, doctors or physicians can be, one-minded, right? And, we have patients that are like, I always want to go to younger doctors because they know the newest technology out there. And you definitely bring that to light, because you not just know how the States does things, you know what they do in Europe, and you kind of have this blend of like, well, depending on his patient, like, am I more towards, the States philosophy or the European philosophy, right? Or do I need to do it like a blend? And I think that's makes you very versatile from a skill set perspective, because not everybody's hip or knee is, the same, right? When you're operating on them, and every case is a little different too. So that's definitely a very unique thing that you bring to the table for sure.
Right. One of my mentors once told me that, there are a lot of different ways to do things in orthopedics, as you've seen, right? There are different ways to do knee replacement, different ways to do hip replacement. And he told me that, if there's one best way, then every surgeon would do it that way, right? The reality is there are a lot of different ways of doing things. I've seen a lot of those different ways. I can do them. And I think what I will try to do is sort of tailor what I offer to the patient, given their specific situation, given what their knee looks like, given what their skin looks like, given their medical problems, right? And sort of tailor it according to that specific patient. It's not a one size fits all procedure.
We do something very similar in our clinic as well, where, everybody comes in with hip or knee pain. Well, the cause is different. So the program has to be different as well, right? So I love that you definitely mentioned that for sure. So, Dr. LeBrun, can you tell me about your ideal patient?
Yeah. So ideal patient, I mean, motivated patients do better, right? So a patient who's motivated, who has goals, like that patient is going to do better than a patient who doesn't have those goals, right? So ideally, I want a patient who is wanting to return to a quality of life they know they could still achieve, and their knee is just getting in their way, and they've tried everything else and it's just not working. Like, that is the type of patient who's a good candidate for a knee replacement, right? So it's not my goal to try to sell a knee replacement to anyone, right? It's my goal to make sure that patients are informed, and are then able to make a decision for themselves about whether a knee replacement is the right thing for them, right? So my ideal patient is someone who's motivated, who has goals in mind, whether that goal is getting back onto the golf course, getting back to pickleball, getting back to hanging out with their grandkids without pain, whatever goal that is, I want to help them achieve that, right? And so that's really like the ideal patient.
And what does the process look like to work with you?
It's 3 steps. So step 1, give my office a call and we can meet, right? So we have a consultation. I learn about you as a patient, get your history, understand the treatments you've tried, the treatments you haven't tried, take a look at your x-rays, physically examine you, try to understand what your knee looks like, what your knee feels like. And then after assembling all that information, have a honest discussion about where we go from here, right? And many times, patients haven't tried all of the different conservative options we have, right? That might be bracing, that might be physical therapy, right? That might be oral medications, topical medications. Once they've tried those and sort of exhausted those options, we then move on to trying something called an injection. So like a steroid injection into the knee, right? Which can provide good but temporary relief. And for some patients who have tried that and it worked great, but now it's not working so well, that's the point at which you transition the conversation over to, hey, maybe we should consider talking about a knee replacement. And so for that subset of patients that is, interested in knee replacement, we have that conversation, we agree that's the right step moving forward. The next step is, check all the boxes to make sure you're prepared for surgery, both medically and at home, right? Meet with your internist, cardiologist, pulmonologist, whomever. And then day of surgery itself, right? So it's really 3 steps. Meet with me and we decide where to go from there. If knee replacement is the right option for that patient, be medically ready for that procedure, and then the procedure itself.
Yeah, I think education is key, right? The more you educate a person, the more they have better information to decide, like, okay, is surgery the right option? Or have I really tried everything I thought I've tried already? And, we totally believe in education first and then letting the patient decide what is the best option, right?
Yeah.
So, you mentioned you educate them and then you take a look at an x-ray, right? And then see what they tried or what they haven't tried, right? And then see if surgery is a potential option. Is that the process you pretty much go through?
Yeah, pretty much. And like I said, a lot of patients haven't tried everything yet, right? Before they're going to knee replacement. There's some subset of patients that's common. They say, look, I've tried everything. Like, I'm ready. I need the knee replacement. But most patients, they haven't tried everything, right? And so, for example, a patient may have put a little icy hot on their knee and they realize when their knee bothers them too much, they have to slow down and sit down, but they haven't actually tried physical therapy, right? They haven't tried taking Tylenol and ibuprofen or other NSAIDs. They haven't tried injections yet. And so a lot of those patients, it's more about guiding them toward what options they have on the treatment ladder. And once we get to the very, very, very top of that ladder, that's when we start talking about knee replacement. It's not always the first visit that we start talking about that.
And what does a typical recovery look like after total knee replacement?
Yeah, so I like to think about it. I call it the rule of threes.
Okay.
So rule of threes for a knee replacement. 3 days, you should be walking around the house doing basic activities of daily living. So 3 days after surgery, basic activities of daily living in the home, right? 3 weeks, you should be able to walk outside and weaning off or already off whatever assistive device you may have. So that's a walker, cane, crutches, right? So at 3 weeks, basically no assistive device, able to walk outside easily. 3 months is where most patients feel like they are over the surgery. So that's 90 to 95% recovered. Full recovery after a knee replacement, as you well know, can take a year or more, right? Until patients are 100% there. But at 3 months, most patients are about 90 to 95% recovered. They can get back to all the things they were doing before, whether that's golf or pickleball or tennis or what have you. And they can do that with better function and less pain. So that's the rule of threes. What I like to tell patients is that for the first 4 to 5 weeks, you may not like me very much because, and you can attest to this, I'm sure, knee replacement recovery is hard, right? I mean, when you see patients in those first few weeks, like, what are they like?
They're cranky. They haven't slept so well, right? They're like, oh, I'm in pain. Is this their first knee replacement? They never obviously experienced it before. They're like, is this normal? Is this damaged, right? Is there infection? So yeah, it's tough.
Yeah, it's tough. And that's why I try to tell patients before we ever do the knee replacement, it's like, look, if we decide to go through this for the first 4 to 6 weeks, like, you're not going to like me very much, right? And then if I've done my job well and you've done your job well, then after that 4 to 6 week period, you're going to start to think, oh, this was worth it. But it's not like the next day. It's not like the next day the knee feels 100% and you're like, I'm ready to go, right? So it's a process. Knee replacement's a process. And I think one point that confuses people sometimes is knee replacement is a slower recovery than hip replacement. They are not the same procedure. Hip replacement patients can feel pretty darn good shortly after surgery. Knee replacement, it takes a little bit longer.
Yeah, I mean, it's funny you mentioned that because literally when we do evaluations for people coming, same week or maybe a day after knee replacement, we tell them straight up, like, hey, I'm not sure if your doctor told you this, but you're not going to like us that much, but you'll thank us, a few weeks from now.
Right.
Like, we're just going through a season of hard and, not so happy. And then, but it's going to go over if you do what we tell you to do, right? And show up for your appointments.
Right.
So I definitely think, that's kind of where we dive back to, like, education first, right? If you manage their expectations and you educate them, like, hey, this is going to happen. And if it does happen, they're like, all right, at least I knew it, right? And if it doesn't happen, great. Like, I was the lucky ones, right? But yeah, the rule of threes, is that something you kind of created or someone taught that to you? I never heard that.
One of my mentors taught it to me. Yeah.
Okay.
Yeah, I was with him in clinic, and he was talking to a patient about what knee replacement recovery looks like, and I just like that. To be honest, there's the hip replacement rule is rule of twos.
Okay.
So it's very easy. So hip replacement, just replace all those numbers with two instead of three, and that sort of shows you how a hip replacement recovery is like. Obviously, these are averages, right?
Right. Right.
So you have some patients who feel great less than 3 months out from knee replacement.
For
You have
sure.
some patients who at 3 months still don't feel that great, right? So that's an average, but it's nice to give people sort of a range of expectations and a ballpark of like, all right, where am I going to be at 3 days? Where am I going to be at 3 weeks? Where am I going to be at 3 months?
Yeah. It's funny you mention that because I never heard of rule of threes before, but usually
Mhm.
patients will ask us like, hey, how long does it take? And we'll tell them like, hey, there's no like definitive because everybody's different, but typically around 90 days is pretty much where you should feel, like you're 90 to 90%, better. And then, 6 months to a year is what most surgeons will tell you.
Right.
So we try to manage expectation right off the bat as well. But I'm gonna have to steal that one, the three
Yeah,
rules. Yeah,
go
that's a
for it.
that's a
Go for it. Yeah, yeah,
yeah,
yeah.
for sure. What is something that, a potential patient don't know about surgery, but they should know before getting a total knee replacement?
Yeah. So that's a good question. There are a couple misconceptions about knee replacement, and I think some of them come from patients who got knee replacements a decade, 2 decades ago, right? Even frankly, 5 years ago, because we are doing things very differently now than we were even 5 years ago, right?
Mm.
So 5, 10 years ago, most patients were staying in the hospital for a few days to a week.
Yep.
Many patients who had knee replacements got drains in their knees, so they had a little tube going in their knee and it was draining out blood for a day or two, and that means you got to stay in the hospital until that comes out. Most patients were getting up and walking a little bit a few days out, but not that much. Now it's very different, right? So now most patients either go home the day of surgery or the next day, right?
Mhm.
We're not using drains anymore. We're not putting tubes in people's legs and having them leave surgery with that. Most patients go home the same day or next day. They're up and walking that day, right? And we're not necessarily talking just standing at the edge of the bed. Like most patients are able to get up, walk around, maybe walk to the bathroom, walk around the hallways of the hospital, walk to their car, right?
Right.
So that's a very different uh, immediate post-operative period than what it looked like 5, 10 years ago. And I think a lot of patients are surprised by that. They think they're going to be in the hospital for several days. They're not, right? Most patients are not in the hospital several days. The flip side of that is that something we already talked about. They may have heard that their friend got a hip replacement and they were like back playing with their grandkids 2 days out and like feeling wonderful, right? A knee replacement takes a little bit longer for that level of recovery to happen. And so the immediate postoperative period is much better than it was 5, 10 years ago, but the entirety of the recovery period still takes a long time.
I know we briefly spoke about this where some surgeons are telling their patients coming out of knee replacement to kind of hold off on physiotherapy for, a few weeks and stuff. And obviously, like we talked about earlier, not every patient's the same. So there are some patients that might have to go through those situations where they wait a few weeks for PT. And some, it's like, hey, go to PT as soon as possible. So can you elaborate on, why some surgeons might feel like that is the more adequate route versus, hey, let's get up and go to PT right away to, get your function and strength back up?
Yeah, yeah, absolutely. So the rationale for some surgeons to delay PT is that they want to give the knee time to like quiet down and calm down, right? Which is a very reasonable thing. Um, I think what you and I have talked about this a little bit. Sometimes it's hard to get into a physical therapist's office, right? It's not always easy, right? You're busy. You've got a bunch of patients, right? And so it's important to set that up early. And in fact, that's one of the things that I ask all patients before surgery, right? One of the requirements on our surgical checklist before surgery is call a physical therapist office, get an appointment set up for 1 to 2 days after surgery so that you can start right after surgery, right? That doesn't mean that the physical therapy is going to be really aggressive at the start, right?
Sure.
I agree on the importance of keeping it calm and cool after surgery, right? But you can still be working on gentle range of motion and strengthening without aggravating your knee, right? I would love to hear your thoughts on this too, because this is a subject of ongoing discussion in the orthopedic community. But I would love to hear your thoughts on what you think the role of PT is right after surgery.
Yeah. So, I mean, for us, the first 2 weeks, like you said, the patient, you told the patient like, hey, you're not going to like me. We tell them the same thing, right? So Obviously, we know they're, inflamed from the surgery. They're not sleeping well. They're in a lot of pain sometimes, right? They're groggy. So negative side effects of all the drugs that's pumped into them, obviously. So what we try to do is manage expectations, just go super gentle in the first few weeks. It's just a lot of like, passive range of motion where we, see what they're capable of doing. And it's a lot of education up front of like, how to move, out of bed, how to get off the toilets, just everyday things. I mean, obviously the ones that succeed really well are the ones that have a support system, but regardless, we try to teach everybody as if they don't have the support system with them 24/7, right? So then over time, they start building that confidence. And that's typically what we do first month is getting that inflammation down as much as we can, get some range of motion, and just start building confidence, put a little more weight on that leg because, their brain's probably like, oh my God, my leg's damaged. When we know is to fix the actual joint, right? So it's getting the brain to recognize like, hey, the surgery was to help your body, but the brain is in like fight or flight mode essentially. So it's just calming the person down mentally, physically, right? So they can have a better outcome, like come 4 or 5 weeks out.
I think that makes total sense. I mean, one of the sayings that I learned from one of my partners here, actually, which I really like, is, a knee replacement is sort of like building a house. So my job as the surgeon is to deal with the bones and the implants. And so that's like the foundation of a house, right? So my goal in surgery is to give you, the patient, a really good foundation for your house. Everything that happens after, putting up the drywall, putting up the walls, the frame, putting down the carpet, the windows, all that stuff, that's the work that the patient does after to get back to the function they want. And, their best friend in that process that I found is typically the physical therapist, right? Who can help them build that house, right? The foundation may be good, but if you don't put in the work and you're not bending your knee, you're not trying to get strength back, the ultimate outcome's not going to be as good as if you're really motivated, you're working with a physical therapist at a reasonable pace and getting your motion back, getting your strength back, getting back to the things you love to do. So that's sort of the something that I've stolen from one of my partners. It's like, it's about building a house, right?
I'm learning all these gems today. No, I think that's awesome.
Yeah.
And I might have to use that one as well, right? Because, like, yes, we teach exercises, but always patients that come in after knee replacement, the last thing they want is more exercise. It's like, I just want to get out of pain, right? And what I tell them is like, okay, I get it, right? There's no need to teach you 50 different things. Like, let's just teach you one or two things, super simple. And that's your like foundational exercises, right? So just like you can go surgery, but just know like that's not the end all be all. That's just the beginning of the new chapter of your life. You still have to support the actual foundation, right? Like so with a drywall, and you're supporting your joints with like the muscles around it, right? And they understand that concept. And if they really want that quality of life beyond just like, staying at home and be able to walk and, be able to play pickleball, golf, or play with grandkids or travel or hike or whatnot, like you really want to, take it beyond just like, walking exercise because sometimes that's just not enough. Right.
Right. Exactly.
Definitely bring up a good point with that. So what's your thoughts on getting physiotherapy before surgery as well as after surgery?
So I think physical therapy before surgery is essential, right? So one of the things, going back to what we talked about earlier, when patients come see me, one of the first things I ask them is, well, what have you tried, right? Have you tried to lose weight, right? For patients who have lost weight, when your knee hurts, do you keep going or do you sort of calm down and stop doing the thing that hurts, right? Have you gone to physical therapy? And for patients who haven't, I will recommend physical therapy, right? Because the vast majority of the time, physical therapy will do one of two things or both, right? It'll either help them with their pain, right? And help them with their function, which is the goal of conservative management in the first place, right? If their knee is pretty much ready for a knee replacement already, it may, at the very least, get them ready for surgery, right? A stronger knee is going to be a knee that recovers better after surgery, right? So, and a knee with better range of motion, that's going to lead to better range of motion after surgery. So I do think physical therapy before surgery is very important to relieve pain, improve function, and get a patient ready for surgery if that's something that's down the pipeline.
For sure.
And then of course, after surgery, like we talked about, that very.
Yeah, definitely. Yeah, that's why we do a lot of education, right? Because a lot of times, back in the day, like you said, 5, 10 years ago, we never got patients that came to us before surgery, right? They just like, I got my operation, doctor said I need physical therapy, and here I am. But nowadays, what we're seeing is, we're seeing patients who are calling in and say, hey, I heard, that physical therapy is beneficial for,
Yeah.
you know, for my knee before I get an operation. What's interesting is we've actually seen patients. We did like a little study in our clinic of patients that seen us before knee replacement surgery, and then after, what their recovery time is versus the ones that came to see us after the fact. And by and large, like at least 60 to 70% of patients that got PT with us before the operation came back faster or bounced back faster versus the ones that just waited till after surgery. So do you think that most surgeons now are kind of lean towards PT before and after, or what's your
I
thoughts on
think
that?
so. I think so. Certainly, at the places that I've trained in here, we're trying to get patients to see physical therapy before, like I said, for both pain relief and better function, and also just preparation for surgery. Yeah,
For sure.
absolutely. Because one of the biggest predictors of success, like a better range of motion after knee replacement, is having good range of motion before, right? And sometimes patients will have a really bad looking knee. They've got bone spurs that are just completely preventing their knee from moving, right? That's something that there's no other way to fix that. That's just something that needs surgery. But a lot of times it's just a knee that's been painful, so they haven't moved it. It's stiff, and we got to get so it's stiff and it's weak, and you got to get that range of motion back and get it stronger before you go to surgery.
So if there's one main thing you want to be known for, what would it be?
Yeah, so that's a good question, and I'm going to give you an answer that might sound a little cheesy, but what I want to be known for. So I went to med school. I decided to become a doctor because I wanted to help people with my hands, right? I want to be a surgeon. It's like I said, when I was a kid, that's what I wanted to do. So I want patients to know me as the person that they can trust when they have a hip or knee problem and they want to talk to someone about it and they don't know what the right move is, you know? So, I bring certain technical skills to it, to orthopedic surgery that I've learned from New York and from Europe that I think are noteworthy, and I would like to be known for them. But what I really want to be known for is good patient care, right? If a patient goes to a number of surgeons around Houston, they're going to get an excellent knee replacement, right? That is absolutely true. Part of building that house is having someone they can trust before surgery and after surgery to help them navigate that recovery. And I want to be that person, right? So picking a surgeon that you trust is one of the most important things you can do in deciding when and how to get a knee replacement, right? So that's what I want to be known for.
There's so much noise in the marketplace nowadays where, patients like, oh, I met with like 3, 4 different surgeons. I'm kind of torn. This guy has this certification. She has this certification. They train under this hospital. They went here. I just don't know, Dr. Wong. Like, what do we do? And, what I tell them is, because when people come for physiotherapy and I tell them, hey, vet us, like go to their clinic and see what they do and compare it and see, hey, who do I feel more comfortable, right, working with, right? And when it comes to picking a surgeon, if I was to ever get one, like it's no different, right? It's like at the end of the day, right? They all have the medical license, they all have done surgeries before, right? But do I trust this person to, you know, do what they said they're going to do and actually, continue with the plan of care afterwards if I have any questions, right? Especially for people that, have never had a hip or knee done before. So of course, like their only experience with it is maybe seeing their spouse or their, parents go through it or the friends, and they're like, "Holy crap! Like it's a lot more painful than I thought.
Mhm.
Do I really want that?" But if they have to have it, the question now becomes is like, well, who do I really trust to not just take care of me, but also if I have any questions or I might be one of those odd persons that might take, that full year or maybe longer than a year to recover, right? So, it's interesting because a lot of patients always think they're exception, right, to the rules, like, "Oh, am I the only one with this problem?" Like, no, you're not. But, when you're kinda, like, dealing with it day to day, they almost think that they are, and that trust is super important, whether it's, choosing physical therapy or choosing a surgeon to operate on, because as we know, like, a knee replacement is not a cakewalk, it is an invasive, operation, right? But with that said, it could change your life. So, yeah, I think definitely you hit the nail on the coffin on that one, trust being a huge factor on that
Yeah,
one.
yeah. What you tell patients about, second opinions or trying out other physical therapists, like I do the exact same thing. Like, if a patient either comes to me for a second opinion or they're maybe I'm going to go see some other surgeon and talk to them too, go for it, right? Because like you got to find a surgeon that you trust to take the best possible care of you, right? And that's like one of the most important, if not the most important thing you could do in getting ready for a major surgery like a knee replacement. So I say the exact same thing to my patients.
So probably one of the most important questions next is, how do people get in touch with you?
Easiest way is just call my office. So the phone number, I can provide it, but it's 346-615-9391. You'll get Riley, my medical assistant. She'll answer the phone. She'll be able to answer your questions, get you on the schedule if you like, direct you to where you need to go. You can also email my office. So it's LeBrun office@fondren.com. But the easiest way really is just give us a call.
Cool.
Yeah.
And I know you're bouncing between Kingwood and, is that Med Center?
That's right. Yeah. So I'll be in Kingwood a couple days a week, Mondays and Fridays. And I'll be in the medical center Tuesday, Wednesday, and Thursday. The hospital that I operate at is called the Texas Orthopedic Hospital. It's in the medical center. And I also operate at some of the other hospitals in the Kingwood area too.
Awesome. Thanks so much for your time, Dr. LeBrun.
Dr. Wong, it's been an absolute pleasure. Thank you so much for having me.